the extracranial cervical blood vessels, specific, carotid, and vertebral. And I'd like to review briefly the pathophysiology of the injury, those risk factors that identify patients that may have these injuries, talk about a screening profile, the classification of these injuries, and then ultimately the treatment. There are three facts perhaps that are most important in considering blunt cerebrovascular injuries. First, the vast majority occur in patients with multi-system trauma. Secondly, nearly 40% have their first symptom more than 18 hours after presentation. And thirdly, anticoagulation can markedly improve outcome. There has been a lot of attention in the past 5 to 10 years in reference to this lesion that heretofore was considered rare. But series from several institutions suggest that the incidence of significant blunt carotid injury and blunt vertebral injury is in the range of 1 to 1.5% of those patients requiring admission for blunt trauma. The pathophysiology involves principally an intimal tear that can lead to thromboemboli, probably the most common reason for neurologic sequelae. Of course, these injuries can also dissect and ultimately occlude the vessel, can form pseudoaneurysms that may rupture, and communicate with the venous system, producing an arteriovenous fistula. The signs and symptoms of blunt carotid vertebral injury are fairly straightforward. And the neurologic symptoms are classic for non-trauma lesions of these two vessels. Importantly, in evaluating the trauma patient, if a neurologic deficit is not consistent with the head CT, these injuries should be considered. These can be remarkably indolent or subclinical presentations. This is a good example. This is a 37-year-old woman who fell from a horse, a relatively mild fall onto her side. She had a brief period of headaches, and on the 7th day after injury, she complained to her husband that her headaches were increasing. She awoke on the 8th day after injury and had deep left hemiparesis that never resolved from an occlusion of her carotid artery. This case points out that these injuries can occur with relatively minor trauma, but most importantly that there is frequently a delay in presentation. The fact that we can potentially identify these before their symptoms suggests that screening would be an important aspect of our trauma care. And we at Mothers have defined a list of criteria that warrant consideration for screening for blunt carotid vertebral injuries. Those principally involved extensive hyperflexion or extension that are generally reflected in mid-facial fractures, severe brain injury, fractures that traverse the carotid canal, and certainly spinal fractures are particularly at risk for vertebral injuries, those involving subluxations, the transversalencephalocranial canal, or body fractures of C1, C3. The reason for the high incidence of vertebral injury with this mechanism is that the vertebral artery is tethered to the first three cervical vertebrae very tightly. And as the neck is torqued, these become stretched and produce an injury. And obviously, they run through the transverse foramen, so fractures of these are very prone to injury the vertebral artery. In order to discuss these things broadly, we several years ago defined a grading system. The purpose of this, again, is to be able to compare experiences and begin to work out management policies. The grades go through progressive degrees of injury. And radiographically, these are quite conspicuous and classic for their presentation, the grade 1 being animal, up to 5 being a complete occlusion of the carotid or vertebral artery. The importance of using grading system to communicate is reflected here. If you look at the incidence of ischemic neurologic events, for carotid injuries, the grade 1 or the animal disruption has around 3%. Remarkably, the vertebral has incidence that's somewhere between 10 and 15%. As you proceed into more severe grades of injury, the risk of stroke increases proportionally, such that patients with grade 3 and 4 are nearly 1 out of 3 at risk for severe stroke. Having then identified the screening criteria, the question is, what sort of diagnostic modality is effective in identifying these injuries? The following tests have been suggested as possible candidates. But unfortunately, the angiogram has been the only one that has been demonstrated conclusively to be 100% accurate for diagnosing carotid or vertebral injury. Several studies have shown that CT angiograms and MR angiograms are only 50% sensitive for identifying these injuries. However, recently, using the advanced multi-detector CT scanners, several groups have suggested that CT angiography may approach angiography for sensitivity. The treatment for these injuries is antithrombotics, but the precise agent remains highly controversial. The standard has been to institute systemic heparin, avoid bolus because many of these patients with multi-system trauma are at risk for hemorrhage, begin at a modest dose, and aim at a modest level of anticoagulation. The alternative approach is to use antiplatelet agents. And now the combination of aspirin and Plavix are recommended by several groups. We are currently conducting a randomized study to identify the optimal. At this point, we do not have data to suggest one is better than the other. The rationale for screening, however, can only be justified if we can document that it makes a difference to identify these injuries early and institute prompt antithrombosis. So several years ago, we looked at our data, now having 10 years of prospective data. And in summary, over the 10 years, we had 73 patients who were given either heparin or antiplatelet therapy promptly after their admission. Remarkably, of these 73 patients, no individual developed ischemic neurologic event. In contrast, of the 41 patients who either were not anticoagulated because of the lack of recognition or were symptomatic after presentation. Almost at 50% of them developed a disabling stroke. And while relatively small numbers, I think the results are compelling that we need to treat these early. Now, if we identify the injuries and institute antithrombotics, we submit it's important to follow this up in 7 to 10 days to look at the nature of these injuries. Because, in fact, they change radically. We have found that nearly 60% of the grade 1s improve to the level that we no longer feel anticoagulation is necessary. Conversely, almost a half of the grade 2 injuries develop into pseudoaneurysms that are at risk for rupture. The management of the carotid pseudoaneurysm, however, remains highly controversial. The aneurysm itself, of course, serves as a nidus for platelet aggregation and embolization. And there have been reports of rupture, although these are exceedingly rare. Due to the increasing use of stents in atherosclerotic carotid disease, a logical treatment would be to use stents in these patients. We've had a modest experience in these. We evaluated this last year. We have nearly 50 pseudoaneurysms that persisted after 10 days. And of these, roughly half were stented and a half were treated with antithrombotics. Much to our alarm, however, those treated with stents, 45% were occluded. Conversely, only 5% treated with antithrombotics were not. Thus, we are concerned about the use of stents. At this point, in injured patients, they appear to be different than patients with atherosclerotic disease. So, in summary, aggressive screening for blunt carotid and vertebral injuries is certainly warranted. The incidence of patients admitted with blunt trauma exceeds 1%. Angiography has been the gold standard, but CT angiography may well become acceptable for screening. These patients warrant prompt antithrombotics. However, again, the optimal regimen remains debated. At this point, the choices are between heparin or antiplatelets. It's important to repeat the studies at 7 to 10 days to characterize their lesion. And finally, while stents appear to be a logical solution to pseudoaneurysms, our experience suggests it's premature to use this as a primary treatment. Thank you very much for your attention.